Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today I want to encourage you to follow along as we talk about Invisalign attachments. If you want to follow along with this blog article, I just published it. Today is the 6th of September, 2020. You can go to my website at StraightSmileSolutions.com and go to the About Us section and go to blog, and this would be the most recent blog that's on there. So in this blog, I go through, I believe, 7 or 8 tips about attachments and auxiliaries for Invisalign. And these are just things that you're not going to find in a textbook or anything. Just like if you asked an orthodontist, hey, give me your top 8 tips about Invisalign success in terms of attachments, these are my personal tips. They might be different than someone else's tips. This is just what I've experienced. Those who are part of my consulting group, who are doctors that are in my network, they've heard these all before, so they may agree or disagree. But anyways, I'm going to take you through 8 of them. Again, feel free to follow along by going to my blog. So basically, and you can find it by going to the About Us section and then going to blog. Okay, so number 1, number tip, if you can put attachments, you can put attachments on both the lingual and palatal of teeth. So attachments don't have to be just on the cheek side or the lip side, they can be on the inside as well. And if you put 2 attachments on, it really, really helps to unravel a rotated tooth, especially premolars, but you can also do it on canines. I don't usually do it on anterior teeth, but you could if it was on like really rotated lateral or something. It's just gonna be twice as efficient if you've got an attachment on both front and back. Now, of course, if you've got it on the back of like some top teeth, you're gonna need to remove that attachment eventually otherwise you're gonna have an interference, right? It's gonna work almost like a bite tab. But while you're spinning it, you can leave it on, and all you have to do is ask for it. They're not gonna give it to you unless you ask for it. Number 2, so Invisalign needs more attachments than any other system because of retention. So their material is pretty flexible. If you've seen my videos where I compare Invisalign to other aligner systems, it's super elastomeric, which is great because that lowers the forces for the teeth. It's healthier for the teeth. It's more comfortable for the patient, but it is bad because you need a lot more attachments. And also their trim line is like super scalloped, so they need like a ton of attachments. So a lot of these attachments that you see on your cases, you wouldn't need them if you're using a different aligner company. So don't get all hung up in the attachments because sometimes they're on there just to hold the darn thing in. Also, on one case you might need a lot and others you don't, just because of the shape of the teeth or the height of the clinical crown. So for the most part, honestly, I try not to overstep kind of bossing the technicians around with attachments unless I really don't like it. I let them do their thing, and then if I look at it and it doesn't make sense, I'll ask for things. What else? Number 3, I always put attachments on for extrusions of incisors, upper and lower front teeth, canines too, because there's often not a height of contour and it needs something to grab onto. So if it's got a blue dot or a black dot, or if I even see extrusion, I'm gonna ask for one. For a flat tooth. What else? I always put attachments on for rotations of incisors or premolars. If it's, canines too, pretty much everything. If it's more than 15-20 degrees. So I just ask for one because it's just gonna be much more efficient. You can also ask for full-sized attachments. Full-size vertical, full-size horizontal. Full-size vertical would be for extrusions. Full-size horizontal would be for extrusions. Full-size vertical would be for rotations. Power ridges, because we're talking about auxiliaries too, are those little, they're like nubs that go in towards the tooth, actually touch the tooth, unlike a nub that goes out, that would be a bite tab. I use bite tabs all the time for basically anyone with a deep bite is going to get a bite tab, anyone with bruxism is going to get a bite tab, anyone that clenches is going to get a bite tab. You're not necessarily going to know that by looking at their case. It only takes a couple of posterior open bite cases to realize how wonderful bite tabs are. So I tend to use bite tabs all the time, and they're not going to put them on unless you ask for them. You have to ask for bite tabs. They're not going to end up in your treatment plan if you don't ask for them. So you've got to know when to ask for them. I tend to underuse them instead of overuse them, but I should use them more. Every time I don't put one on, and later I kick myself that I didn't put it on. But yeah, power ridges are the nubs that go in. They're for torquing a single tooth. They also cause the plastic to jet out, and they cause more discomfort with the patient in terms of fit issues. So if you don't need one, don't put one on. Chewies are super duper important. You need Chewies to fully engage your attachments. If you're not spending the $1 on Chewies and giving one to every patient and explaining patients that they need to use them regularly and how to use them, you are not getting the best possible outcomes. And again, look at your revision refinement rate. If your revision refinement rate is above 40-50%, you're doing something wrong. So Chewies is a $1 thing that you can buy at Amazon. Give your patient one, explain the why behind it. I've got a bazillion videos on how to use Chewies and how that $1 investment can help you decrease not only your chair time, but increase patient satisfaction, your lab bills, everything like that. Less chair time, less visits to the office is more ROI for you, more profit. Because every time there's a patient in your chair, you're getting less profit, right? Because that chair could be used for something else. Precision cuts and elastics. I pretty much stopped using their recommended precision cuts, the slots, and now I'm all about just bonding to the tooth, almost like you do in braces. It just works way, way, way better. I know it's an extra step, but it is so much better for adjusting midlines and adjusting AP. So you can ask for that. I always say just all cutouts, no slots. And of course, it's an extra few minutes in the chair, but you'll get a way, way better outcome. And you can use heavier elastics. And also there's less fit issues because if you're attaching your elastic to the slots, it's like a counterforce to seating it, it's like the opposite of a Chewy. So ideally we want the darn things to stay in and not have something pulling them out all the time. Lastly, I think plastic is better than braces on open bite cases. Opposite maybe on deep bite cases unless you have the bite turbos. I love plastic for open bite cases. You can do magical things, but remember, open bites don't just happen. I mean, you got to figure out what is the etiology of your open bite, and this is something that I say so often. Your open bite is either caused by a past or present habit, or it's caused by a skeletal issue, one or the other. So your past or present habit could be a thumb habit, a finger habit, a tongue habit, an oral habit, just biting fingers, biting pens, could be an airway issue, could be mouth breathing. The problem is you can go and fix it with Invisalign, but it's not gonna retain. First of all, it's gonna take longer if you don't fix it first. And then I can't tell how often we see cases that just unravel. They don't retain, even though you might have made the best possible retention and the patient's wearing it, because the force of the tongue is something to be reckoned with. The tongue is extremely strong, and it's stronger than your retention. Even if you do bonded retainer, even if you do an Essex over it, most likely it's stronger. And you're gonna see rapid relapse in these cases. 3, 4, 5, 6, 7, 8 months, and most likely you're gonna have to retreat that case for free because you missed the most important part, which is treating the myofunctional. And that's not always easy. Now, treating the myofunctional could mean having a myofunctional therapist. It could mean putting in a fixed appliance for 6 months ahead of time. It could mean putting in a removal appliance and having them wear it at night over the aligners. There's a lot of different options there. It could mean sending them to an ENT. It could mean taking some time and fixing the mouth breathing, finding what's wrong with the nasal airway, treating the allergies. There's a lot of stuff that may not be dentally related that comes with these open bite cases. So you're gonna have to have an interdisciplinary approach, which might include the primary care physician, or referring them out to a sleep physician or an ENT. So don't necessarily take an open bite case. Anytime you see an open bite case, as far as I'm concerned, it's a huge red flag. It may not be something that you want to start right then until you figured out what's causing it and you treated that. Now, you could start the case and treat that first, but I wouldn't necessarily start the aligner until you figured out what the problem is. And if somebody's claiming there's no problem, then you're not doing your detective work well enough. You have to be a detective with these cases and find out what's wrong and treat it. Something is 100% causing it. And even if they tell you that they had a thumb habit at age 5, well, if you're still seeing open bite, I don't buy that, because a thumb habit at age 5 that ended at 5 doesn't cause an adult open bite. It would have fixed itself, or, it's not gonna be something that's totally obvious, So that means that maybe they're mouth breathing at night because of the thumb habit they had at age 5, and it's a perpetual problem, and that's still gonna unravel your case. So again, if you can visualize an open bite, there's something currently wrong. Could have been caused by a past problem, but there's still something currently wrong that needs to be treated. Often patients are totally unaware that things are happening at night, and that the things that are happening at night is making their bite worse. And often they're not telling you the truth. I can't tell you how many patients are thumb suckers, active habits, biting fingers, biting nails, stuff like that, even sucking thumbs at age 60, 70, 80. And nobody knows. They don't, it's a complete shame spiral. They're not going to tell you in the chair. You're going to have to dig into it in a very friendly way and explain the why behind it, and just say, hey, in those circumstances, I say, look, I know you want to straighten your teeth, but I can't straighten your teeth till I find out what's causing your open bite. And unless I can find what's causing your open bite and treat that, I can't fix your teeth, because anything I do is just going to relapse. And I don't want you to invest your money in something and have it go away, even though we've both done our best job. So I need you to be totally honest with me about what's going on here, and that, usually they'll open up after that. So there's some good scripting for you. But again, sometimes they don't know. So anyways, hopefully that was helpful for you. Please do visit my site and go to the blogs to learn more. And don't hesitate to reach out if you have any questions. All right, thanks so much.